Good evening and welcome to IMED Radiology's cardiac webinar, Getting to the Heart of It. As we gather for this webinar, I'd like to acknowledge the traditional custodians of the land which we're all living, learning and working upon this evening. We acknowledge the elders past, present and emerging. My name is Laura and I'm the Marketing and Education Coordinator at IMED Radiology. Tonight's session will be presented by our highly respected radiologist, Dr. Kenneth Sesel, who will focus the evening on coronary artery calcium scoring and its role in general practice. I'd also like to introduce our facilitator for the evening, Dr. Philip Perlstein. Dr. Perlstein is a prominent and long-standing GP down here in Melbourne who founded the Midtown Medical Centre in 1988 and co-founded the Melbourne Sports Medicine Centre in 1993. He's been involved with the Carlton and North Melbourne football clubs and worked as a doctor at the 2000 Olympic Games. Dr. Perlstein's also been a member of the selection panel for medical students and a tutor of undergraduate students at Monash University in the Department of General Practice. Today, Dr. Perlstein remains active in his founding practices in Melbourne in a mentoring and management role. Before I hand over to Dr. Perlstein, I do have one housekeeping item for the evening. There will be an evaluation form to fill out at the conclusion of the webinar. Please stay online and fill this form out. Your feedback is really important in helping us keep these sessions as educational and relevant as possible. I'll now hand over to Dr. Perlstein, who will introduce our speaker for the evening. Thank you.
Thanks, Laura, and good evening, everyone, and welcome to this IMED webinar focusing on cardiac CT calcium scoring. Heart disease is still very common in our community, and doctors and patients alike are all keen to initiate appropriate preventative measures when they're applicable and available. So this topic is really relevant to our everyday practice. We're very fortunate to have such a prominent expert as Dr. Ken Sesel guide us through this process. Please feel free to ask any questions during the presentation, and we'll attempt to have Ken answer as many as possible after the presentation. There'll also be some true-false poll questions during the presentation to check that everybody has remained awake. Now, Dr. Ken Sesel is an academic radiologist, part-time senior staff specialist at St Vincent's Hospital in Sydney, and the clinical director of IMED Radiology, Bondi Junction. He trained in the USA under one of the world leaders in the field of CT, coronary angiography and calcium score, Dr. Harvey Hecht. Ken established a cardiac CT service at St Vincent's Hospital, Sydney, and worked with cardiologists to provide a combined service. He has several publications in the field of cardiac radiology and was the Toshiba cardiac CT course leader at St Vincent's Hospital for 10 years, during which time he trained over 200 cardiologists and radiologists on the use of CT in coronary artery disease. Dr. Sesel has been an invited guest speaker at both national and international conferences on this subject, and he's scheduled to participate in an international Philips coronary artery CT training course in Singapore this year. Thanks, Ken, for leading us through this important discussion.
Hello and welcome. The topic today is getting to the heart of it, understanding coronary artery calcium score. This is a list of cardiac imaging available to us all. And I've been asked to talk about cardiac imaging and to focus mainly on the calcium score. I would touch on some of the others in this list, but not in depth. My objective is the following. Most importantly, the take-home message is that CACS, calcium score, is a simple, cheap, non-invasive screening test. It is a number value, and the only way to get this number is by using a CT scan, rather than using a pathology lab as you would use for other tests. In contrast, a CT coronary angiogram is a detailed anatomical test with contrast injection and shows calcium and soft plaque, stenoses, stents, bypass grafts, valves, myocardium, pericardium, etc. Perhaps a talk for another occasion. So in the objectives, we're looking at the calcium score, radiation, how to utilize results, some of the misunderstandings, a little bit about the costs, the limitations, and a brief mention of some of the other studies. So firstly, I'd like to tell you why this is so important. Why is it such a big deal? The following slides will answer the questions, hopefully, and it's the reason why I'm so passionate about the topic. I'd like you just to think about how much time, energy, health dollars are spent in areas such as breast screening, colon screening, prostate, osteoporosis, etc. So cardiovascular disease is the leading cause of death. It counts for 34% of all deaths in the Western world. It kills 1 Australian every 11 minutes. Nearly 1.5 million people are disabled by cardiac incapacity post-MI. It affects 1 out of 5 Australians and 2 out of 3 families. This is a brief few notes from various publications. I've listed the publication at the bottom. The lifetime risk in a 40-year-old male of coronary disease is 49% and in a female 32%. It is the single largest killer of males and females, and this excludes pandemic stats, so let's not bring that into the discussion. It's a leading cause of hospital admissions, with coronary artery disease making up 16%. Now, this is a really interesting one. 63% of females, 50% of men with sudden cardiac death. Now, when we look at relative death rates from various conditions, this data is from the United States, but it excludes pandemic data, but it shows how the diseases of the heart, you can see the total here in the number of deaths per 1,000, is right up at the top. And if you see the next one on the list, malignant neoplasms, and this includes all cancers, so this is the total of all cancers, and then we have all the others. Cardiovascular disease is the next highest. So the point about it is that the relativity of heart disease as a total compared to the total of all cancers, and this is why I'm so passionate about it, and this is why I hope that at the end of this talk you will all take it on board and think about screening and looking for atherosclerotic disease in your patients. This slide just shows the atherosclerosis and the current theory of what happens and how it happens, and basically the progression from the soft plaque, the deposition, the platelets, the thrombus, and the occlusion. So what can happen to the soft plaque? It may calcify, which represents stabilization and healing of the soft plaque. What would happen to the calcium score as soft plaque heals? It will start increasing. So it doesn't necessarily mean there's new plaque. Of course, there may be new plaque, but it could just be the healing of soft plaque if the patient's on treatment. The thin fibrous cap may rupture, exposing thrombogenetic material to circulating blood, leading to the acute thrombotic occlusion, as I showed you in the progress in the prior slide. It may hemorrhage into the plaque, as demonstrated in the slide, and you may get embolization. Now, there are numerous calcium score publications that have been out for the last 30 years. This one is from 25 years ago, this one from 14 years ago. Harvey Hecht was my was my teacher, the person that I learned most of my cardiac from, and an extremely well-known personality in the world of cardiovascular. He's actually a cardiologist, nuclear physician trained, and extremely passionate about calcium scoring and the fact that it should be using for screening. Now you'll see that in his article, he showed that calcium score can identify the pool of patients out of which 95% of acute events will emerge. And this data has been confirmed in multiple subsequent publications over many years. And we now have long-term follow-ups as well. Just remember when you look at the number 95% that unfortunately there are 5% which it won't do that for. And that 5% is really, you can translate that as 1 out of 20, which is not a completely insignificant number. You will certainly get 95% of events if you use the calcium score technique. So this is a quote from the head of the journal, editor of the Journal of Atherosclerosis, saying the best way to look at atherosclerosis is to demonstrate atherosclerosis. It sounds pretty straightforward, and basically that's what we're doing when we do a calcium score. That is the actual measure of disease, which is actually healed, but it's a measure of atherosclerosis. Now, the calcium score provides you, when used in the right way, to provide you a predicted risk of an event in a particular patient. The way to obtain this score is by non-invasive, non-contrast study. This enables the measurement of the calcific plaque and provides the total coronary artery calcium score. It's a marker of atherosclerotic plaque burden, and it's an independent predictor on its own of future myocardial infarction and mortality. It should be thought of as a predictive factor together with all the other traditional risk factors. But it is, of all of them, the most powerful of all risk factors. By the way, the next most powerful is genetics and significant family history. So we come now to the first of our poll questions, and I'll get you a moment just to read that and to think about your answer. So it's a true or false. Calcium score on its own is a strong predictor of atherosclerosis. I shouldn't have to give very long for that question. So the next thing is, why do the calcium score? Well, it's only for asymptomatic patients. I think it's important to emphasize that. If you've got a patient with symptoms, you've got to be thinking about the other tests. In an asymptomatic patient, you want to assess the risk factors. Now, general practitioners will often need to decide whether to put a patient onto statin therapy in an asymptomatic, particularly if they're borderline or intermediate risk. Studies have shown the combination of calcium score by adding it in with the Framingham and Reynolds scores. These are quite similar. It's the Reynolds is a little more advanced. By putting it into those risk scores, it enables a much more powerful tool than any of the others on their own. And it enables an individualized risk assessment for that particular patient. So the calcium alone is the stronger predictor than the other factors, with family history the next. Now, primary prevention and screening in medicine is usually in the hands of general practitioners, where it should be. The coronary artery calcium score. It's a reliable marker of atherosclerosis and vascular age. It is consistently the best predictor in numerous studies for many years. The site of the calcium in the vessel has been shown to be unrelated to the site where stenosis or new lesion develops. One needs to think of it as a number, which happens to need a CT scan in order to obtain it. And there's very little, if any, anatomical value. Now, how do we obtain it? It's a non-contrast CT scan. We use ECG gating to stop the movement of the heart and to capture it more accurately. The radiation dose is minimal. It's about 1 to 2 millisieverts. Here's the comparison. The chest X-ray is approximately, a PN lateral is approximately 1 millisievert. The background radiation living at sea level, by the way, is 3.5 millisieverts in Sydney and around Australia, whereas in somewhere like Denver, Colorado, which is at 12,000 meters, it's 12.5 millisieverts. You can see that that's so much higher than the dose of just a little calcium score. So the radiation dose really is not an issue at all. The Agatston score, which is named after the gentleman who first developed it, includes calcium which has density greater than 130 H units. And that's the way it's defined. So the limitation of this is that if calcium is 120 H units or a little lower, or even 125, it will not be included in the score. So you can actually get little bits of calcium and you can have a calcium score of 0. And in most cases, that is the reason why, unless there are other technical explanations. What happens is the technician goes through the scan slice by slice and he just puts a little circle around the calcium. He adds it into the vessels until he gets a total. The calcium in the diagonals, for example, is included in the LAD, where possible, and the circumflex includes its marginal branches. But it's quite easy to add a diagonal into the circumflex or vice versa. And sometimes you get an intermediate ramus artery, which will get added into either the LAD or the circumflex. It doesn't really make a difference. There's no relationship between the actual site of calcium and the site where a new lesion occurs. And in fact, it's more often than not in non-calcified areas of vessels. My mentor, Harvey Hecht, did something like 15,000 cases together with Gary Rubin doing the catheter studies at the Mount Sinai, New York, starting 25 years ago. And he has found that in his experience, and he's actually published this on the well, that more often than not, the areas of very dense calcium are the areas of the healed plaque, and the soft plaque is in other vessels in other areas, and that's where the new lesions occur. So it isn't really of any major significance where the calcium is actually located. The only exception might be that if your left main coronary artery is heavily calcified, then this can be an important finding, because left main, we know, is the most critical of all vessels. The other thing that can be useful is if the calcium is very spotty and lots of little calcific foci which are spread out along the vessels. That tends to have slightly higher risk than more proximal areas of very dense, large calcium. But those things are really not relevant to this kind of presentation, where we're looking at obtaining a total calcium score and then putting it into calculators to obtain the personal risk information. This is a 59-year-old Caucasian male, and these are the numbers that really matter in terms of working out his score. Smoking history, diabetic, family history, hypertensive, cholesterol levels, medication, blood pressure. This is the calcium score. The software picks up the calcium and the tech goes in there, he puts a circle around it, and he just gets a total number out of that. This is LAD, that's circumflex, that's the ramus intermediate. It doesn't really matter. This would, you cannot add it in twice. It's just the software is really good at it. You go through to the next slice and you add in the calcium on the next slice until you get the totals. This represents severe calcification. This is what the score looks like. Yes, you get the various measurements, and we happen to have put some of them in the LAD, left main, RCA. These are the numbers. Some people request some of this information. I'm not really quite sure why they want this, but what really matters is the total coronary artery calcium score, and if you like, the volume can have some value as well. But that's the number you want, and then you get a percentile based on where it sits on the percentile for the age and sex, and it fits onto the graph in this patient on the 96th percentile. Now, this is the basic category that the calcium scores get divided in, basically mild, moderate, and severe. And you've probably seen this, and often it's put as a rider at the bottom of reports, and it is useful in determining, how to manage the patients. But they're very, very broad categories, as you can see, and it's not personalized for that particular patient. It's much more powerful to take the internet browser, search up the MISA risk calculator. MISA is the multi-ethnic study of atherosclerosis, and it's an enormous study which was funded by the United States government with long-term results and outcome studies, and based on that they created calculators which actually give you a very specific calculation by including the calcium score together with the other risk factors for that particular patient. If you search up the MISA risk calculator, it's very easy to find the site because it'll come up the top 3 or 4 in Google. Once you've found it, I suggest you mark it as a favorite, so that next time you go on there, you can just open it up with the click of a button. What you'll get is something like this. In fact, this is what you should get, and you just fill in all the data. In Australia, we fill in the millimoles per litre, and you'll fill it in like in that particular patient. It will automatically do the conversions and all the calculations. You hit the calculate 10-year risk, and these are the results in that patient. You'll see that the estimated 10-year risk of an event of a person with this risk factor Obviously, age, sex, all those other factors included with the calcium score included in the calculation is 18.8%, which, as you all know, is a very high risk of having an event within the next 10 years. This statement here is that the estimated 10-year risk of an event with this risk profile, if we did not put in the calcium score, would be 9%. So what has happened here is that this patient had a significant risk already, but with the calcium score factored in there, the true personalized risk for that patient is provided. And this is an extremely useful and powerful tool when explaining to the patient. It's much easier for them to understand that the chance of them having an event within a certain time period is 18%, as against just giving them a score and other data. It's also extremely powerful in encouraging the patient to be compliant in terms of medical compliance and lifestyle risk factor modification. So we come now to the second poll question. And I'll give you a moment for this as well. I'll read it out to you. So the online MISA CACS calculator enables a personalized risk for the particular patient with a calculated probability of that particular patient having an event within 10 years. True or false? So now I'm just going to mention a few cautions. It is pointless doing a calcium score in a very high risk person where the testing is unlikely to change the management anyway. For example, a diabetic over 60 with other risk factors, someone with familial hypercholesterolemia, you're not going to not manage that patient, and the calcium score isn't really going to influence it in any big way. There's no harm in doing it if you'd like a baseline or if you want to see how they progress over time, but it's certainly not something that is essential if it's not going to change your treatment. It is pointless if the patient is symptomatic or if they've got previous coronary artery disease documented. In a patient, for example, who's got stents, there's no point in doing it because it will actually measure the stents and give you a completely false reading. In someone who's got bypasses, it's pointless doing it. So unless you're really interested in the progression, the stability, or you want to try and look at treatment response, there's not much point. Now, this is a cautionary warning to be careful in the younger age groups. The data becomes more reliable and more robust with the older age groups and over the age of 50 in particular. Remember, coronary artery atherosclerotic disease tends to start at a slightly later age in females compared to males. With the calcium score, I'd caution you to be particularly careful under the age of 45, because if you're concerned about disease in the patient and you get a calcium score of 0, this can be very misleading. I've seen many patients in younger age groups with a lot of soft plaque, a lot of disease. Some of them have even ended up having stents and bypasses, and they've had 0 calcium score. Usually we don't really like to do calcium scores under 45, and ideally, over 50 is the age group when it's best suited to. Increasing score is not unusual with age, but be aware that this may just be to the healing of pre-existing soft plaque. You'd be concerned if the score went from, say, 150 to 250 or 300 or 400 or higher, but from 150 to 185, a movement of 15, 20, 30 would not be particularly concerning. It can even be technical. There may even be just one plaque which wasn't added in last time and was added in the next time. By the same token, a decreasing score is probably a technical fault. There was probably a little plaque there that was added in last time and not in the current one, or it's possible that a little bit of the mitral annulus might have been added in, or a little calcification that was actually in the wall of the aorta and not in the left main, was included as part of the ostium, and it may not have been there. So, you can, with some cases, you can repeat the calcium score 2 or 3 times and you can get slightly different measurements. So it's not a major issue if there's small differences. Remember, a 0 calcium score does not mean that there's no soft plaque. You're not looking at soft plaque, you're not looking at anatomy, you're just trying to get a score out of this patient, and you happen to use the CT in order to obtain it. So I honestly believe that one shouldn't try and get any more information out of the calcium score than that. And if you really want to see what those arteries look like, and you really want to look at soft plaque, and there are indications to do that, then there's a much, much better test to do that. Remember that slide earlier on where I said that you'll pick up 95% of cases with atherosclerotic disease? That means that there'll be 5% which you won't, and beware of the younger patient with the strong family history. I can tell you that I do quite a lot of cardiovascular imaging and a lot of coronary artery CT and calcium scores, and I probably see one case every 2 or 3 days with a calcium score of 0, but who has soft plaque disease. Often it's not major disease, but it's a patient who you may like to treat, because as you know, soft plaque is the plaque that leads on to events. You certainly don't want to give them the tick and send them home and say you don't need any management at all. So you've got to be careful in those younger patients. Just about progression, significant progression indicates worse prognosis irrespective of the baseline. It may indicate that your statins are failing or that the patient is not compliant. A stable score is reassuring, but remember, it still doesn't tell us how much soft plaque there is. A mild to moderate increase hopefully indicates that the soft plaque has been calcifying, stabilizing, and healing. But just remember, there's just a score. We don't really know what's happening in those vessels. It's not an anatomical test unless we do a CT coronary angiogram. I should mention there that when we talk about CT coronary angiograms, we're really talking about patients who have symptoms or concerning factors, rather than in the pure asymptomatic. Now, in fact, even a catheter angiogram will only show the lumen of the vessels, and it may show some calcium, but it doesn't see the soft plaque at all. We have to use other techniques to do it. I think the CT coronary angiogram is the best test. Some call it invasive because you're giving contrast and you're putting in a cannula, and there's the risk of allergies, as there is with any other CT we do anywhere else in the body, but it's a really fairly innocuous test other than that. The only other way to see soft plaque is to do it via catheter study with an IVUS or an OCT, which we can mention later. So this is another case example. This is a 35-year-old cardiologist from Newcastle whose brother died at 32 of a myocardial infarct. Calcium score was not done. There was no point in it. He had a CTCA, and in that CTCA, I can tell you there was no calcium. But what you can see is that he had a tight stenosis of his LAD. That is the angiographic assessment of the stenosis, and this is after he had it stented and treated. So here you have an example of someone with a young patient went straight to the catheter angiogram because his family history was terrible and he wanted to be comfortable. Next patient. Here's another gentleman, 46-year-old now, with chest pain. Now he had a positive stress echo. He didn't want the catheter study, which normally the cardiologist would have done as the next test. So he was sent to us to do a CTCA. There was no point in doing a calcium score at all because he's stress test positive. We need to know whether there's soft plaque and whether there's a lesion. A 0 calcium score wouldn't have helped us. And this patient had a 0 calcium score, yet he had a significant tight lesion and he was forced to have an angiogram and to have it stented. Now, a third patient, very briefly, was a 49-year-old with chest pain, went to ED on the Friday afternoon at St. Vincent's, and I'm a staff specialist there, so I got to see all the details on the clinical background behind this patient. He was sent home and told that he was fine. He had a negative stress test. 3 days later on the Monday, He was complaining again. The GP called me up and said, what should he do? I said, look, we better do a CT coronary angiogram study. The patient did have a calcium score as part of that study, and he again had a 0 calcium score. He had a very, very tight stenosis with soft plaque. Here's the stenosis on the angiogram. That same Monday evening, he had a stent placed in that vessel. A couple of images here just to show you what soft plaque actually looks like on a CT coronary angiogram. We see the lumen, but we also get to see the wall of the vessel, and you can see a tight stenosis here. When there's calcium, this is what it looks like. Often it's just confined to the vessel wall and the lumen's actually fine. Sometimes, like in this patient, it's what we call kissing calcitic plaques on both sides of the lumen, and the lumen is narrowed, and there you see it in the angiogram. This patient's also got an osteostenosis in the left main, and the left main coronary artery is always a more significant, more concerning stenosis. We look for 50% stenosis in the left main before we call it significant, whereas in the LAD or the RCA, it's usually 70%. You'll see here that in the LAD, this patient has a very tight stenosis, which is about 90% or more. And even though this looks like a more significant lesion, one certainly cannot ignore the stenosis in the left main. So a couple of examples here of what we see when we're actually looking at anatomy and what calcium looks like when we look at the anatomy. When we do the score, we just capture that value as a number. We now get to the poll question number 3. The question is, if the calcium score is 0, the statement is, if the calcium score is 0, the presence of disease is excluded and no treatment is required. I'll give you a few moments to answer this. So I think the answer here is quite clear, that it's false. You cannot completely confidently say a patient should get no treatment if the calcium score is 0. You have to look at the other risk factors. You have to consider if there are any symptoms, and you have to be reasonably confident that before you let the patient go. These two references clarify, in particular, the second one here, which says the calcium score can identify the pool of patients out of which 95% of acute events will emerge. So if you go purely on the calcium score, the truth is that you will be correct for 95% of the patients, because you're going to find the pool of patients that are at risk. You wouldn't have done the calcium score if they were symptomatic. So they're asymptomatic patients. You've got a diagnosis of atherosclerotic disease. You're going to treat them, and you'll treat them according to their 10-year probability of an event, which you would have calculated from the MISA calculator. The caution that I've placed in this presentation, that I have pointed out to you again in the slide, is that 5% can be missed if you go purely on that. So it's just really the old adage is that nothing is 100% in medicine, and even though the guidelines are that you can treat 95% patients correctly using the calcium score alone, you do need to think about that 5% of asymptomatics which could actually have disease. And if you've got patients with diabetes or severe, very disordered lipids, and a very severe high-risk family history, you need to think outside the block and consider if you want to do any other tests, like a coronary artery CT. So the calcium score is 0. This is unfortunately a little bit repetitive, but I have mentioned that the 5% are a concern, and if they have other risk factors, you need to consider that. Now, just on the CT coronary angiogram study, it's not widely recommended for screening of asymptomatic patients, but the reason for this is mainly because of the risk of contrast allergy and also the costs. It's a lot more expensive than the calcium score, and health systems don't really want to pay for it. It's not covered by Medicare. There are, of course, many patients who may choose to have it and are happy to pay for it. The real issue is that you need to fully explain the risks of contrast allergy, and the patient needs to have proper informed consent if they're going to choose to have a study like this done. Now, patients with symptoms should not have the calcium score. They need to have other tests. They need to either have the CT coronary angiogram study, which can be referred by anyone, provided the patient pays for it, and for cardiologists can refer it for certain specific indications, which particularly are around symptoms. And the alternative is a functional test, stress test, done usually by cardiologists or nuclear physicians. Now, this is just another significant precaution, that you've got to be very careful of atypical symptoms like heartburn, back pain, discomfort, shortness of breath, lightheadedness, dizziness, syncope. You may not be sending all these patients with atypical symptoms straight off to a cardiologist to go and have stress tests, etc. You may want to discuss with the patient other options, and CTCA is certainly one of the considerations. One of the most powerful things about a CT coronary angiogram study is its negative predictive value. It has the highest negative predictive value of all tests. It's about 98%, which means that a good quality study done on good equipment in a good unit, reported by experienced specialists, is reliable in 98% when it's clear and it's normal, and you can tell that patient that they don't require treatment. The positive predictive value is not quite as high. It's more around about the 80 to 90%, depends on many variables and ranging varieties of expertise and interpretation. So the calcium score is much less useful in younger age groups. We've mentioned that before. And if someone's got a significant family history, you need to be even more careful. So we come to the poll question number 4. Atherosclerotic disease in Western countries kills more people than combined total of all cancers. True or false? And I'll give you a moment. And hopefully all of you answer true. Now, just talking about costs and availability, currently there's no Medicare item number, but there should be. I believe personally very strongly, and my mentor Harvey Hecht, who's one of the world's experts, that screening should be offered to male patients at the age of about 50. They should be entitled to a one-off scan, and a female at a slightly later age group, either 55 or 60, a one-off scan, and that it should be covered by Medicare. I believe very strongly that the cost savings to the medical system as a whole in detecting atherosclerotic disease early on and instituting the appropriate treatment early on would be enormous cost savings. I'm not an actuary and I can't give you any numbers, and it's not the easiest thing to work out cost savings. You need to look at ICU days, coronary bypasses, stents, the cost of all the other tests involved when patient becomes a cardiac cripple, the rehabilitation involved with that. It's enormous. Medicine is all about prevention and getting in early. So much money is spent on things like mammographic screening, occult fecal blood testing, sending it out to the entire population when people turn 50, and numerous other areas in medicine. And I've tried to emphasize again and again that atherosclerotic disease kills more than the total of all cancers. It's very, very important in all your patients in those age groups. And I think everyone needs to think about it. And yes, we do need to try and convince the government to provide a Medicare item number. But what are the costs? It is variable depending on the unit that's closest to you. It's approximately $100 to $250. The radiologist who reports it only needs 10 or 15 minutes to train them how to do it, because it's a simple test. It's actually done by the technician. And the radiologist is given the number, and he needs to report that number and maybe give a few other little bits of statistical information. It's up to the referring clinician to take that number and put it into the MISA score in order to utilize it optimally. There are very few scanners in Australia which wouldn't be able to do the calcium score, and all they need is a software license. And I know that most of the scanners in the IMED group, 95% of them are all up to the task. I can't talk for the others, but I'm pretty sure that most of them should be. This is a CT acquisition by the tech who adds up the scores. In some centres like my own centre here in Bondi Junction in Sydney, we do a calcium score with every CTCA at no extra cost. As I told you, the radiation dose is small, and I think it's very useful to have that information in there. It's very useful as a predictive factor in the MISA calculator, and it also helps us in a few other little ways, which I won't get sidetracked into right now. So the cost of the CTCA, for example, in our centre is $500. It includes that calcium score, and it does sound like quite a bit of money, but if you're interested, the Medicare bulk billed calculated rebatable rate is about $700 if it is appropriately referred by a cardiologist. And there are only 3 or 4 indications which do fit those Medicare criteria. It doesn't have to be a cardiologist, by the way. I should correct that. It's by specialist referral. So an anaesthetist can refer, and we do get referrals from quite a few other specialists from time to time. Now I'd like to just talk briefly about functional imaging, just to tell you a little bit about it without getting into the detail. It depends on the availability. Generally, it requires either exercise or the use of a pharmacological stressor in order to challenge the heart and to precipitate the ischemia, which is otherwise not detected at rest. And it's therefore a cardiac challenge test. Both stress echo and nuclear stress tests have been around for long before cardiac CT technology advances with ECG gating enabled the studies we've spoken on today. There are numerous studies in stress echo and nuclear studies showing their accuracy, sensitivities and specificities and their outcome studies. And across the board, the accuracy is approximately 80%. Both nuclear and stress echo have about approximately 20% false negatives and false positives. There are some advantages and disadvantages of each test, but these results on multiple studies over a long time. Here's just one of the studies from some years ago. Nuclear and echo sensitivity and specificity, they're both around about the 80%, around about 20% false positives and negatives, and multiple studies come out with similar figures. Now, which one should one do, nuclear versus stress? It depends on what's available to you. The MIBI nuclear study is often selected where a patient can't run on the treadmill, where they might be have a large body habitus or unable to exercise. For the stress echo, so the nuclear stress test works in that situation. It's preferred sometimes for other reasons because it depends on expertise and availability. In the United States, cardiologists are in massive cardiology groups, 20, 30, 40, 50 cardiologists. They have their own scanners and their own nuclear facilities, and the majority of them are nuclear trained as well. And so they tend to do nuclear medicine predominantly. About 70% of cases in the United States, according to Harvey Hecht, who is a nuclear cardiologist, are nuclear studies. Stress echo in the United States makes up about 30%. Interestingly, the remuneration for nuclear medicine studies is a lot higher, significantly higher, in the United States and in Australia. In Australia and Europe, where we have the exact opposite pattern. Stress echo is generally preferred. Cardiologists, there are only a handful of them. There are not very many that are nuclear trained. We have a very excellent one who works with us in our Randwick rooms at the Prince Wales Private, who's an expert in coronary artery CT, and he's a nuclear cardiologist, and that's a major advantage. But generally, cardiologists are not, most of them are not nuclear trained, but they are echo trained, and they're 99% of the time they have cardiac echo in their rooms. They can do it then and there. They can discuss it with the patients. They're in control of the whole process, and 70% of functional tests will be stress echoes, and the patients who can't have them because they can't be stressed properly on a treadmill may be considered for the nuclear alternative that may be studied. As a radiologist who does a lot of coronary artery CT angiograms, I often actually recommend stress tests after I report a CT coronary angiogram, particularly when it is equivocal, borderline, when there are complex, difficult plaques, and I'm not sure if there's a stenosis, say in the LAD, of 50 to 70%. I'm not sure if it's towards the 70% end of that range, in which case it's significant and may need a stent or something else, or if it's towards the 50%. Sometimes with the CT coronary angiogram study, you can't be that accurate, and you do need to know in terms of management whether it's 70% or greater for the left LAD and the RCA, or for the left main if it's 50% or greater. So if we borderline, I'll often recommend a stress test, or at least to correlate the scans with a functional test. I did mention earlier on negative predictive value of CTCA is greater than 95% in multiple publications. So as I said earlier, it depends on availability as to what tests you're really going to be getting in terms of the higher end, more complex tests, and particularly the functional tests. This is an example of myocardial perfusion nuclear medicine test showing the ischemia in the left ventricular wall and in the septum. And this is just a few images from an echo. Remember, the echo is dynamic, the heart's beating, and they're looking at the wall, the wall of the motion of the myocardium to see if there are any defects, in addition to numerous other factors which are taken into account in a stress echo. Now, very, very briefly, the vulnerable plaque, the plaque which is going to actually rupture suddenly and cause sudden death. This is what we really want to try and find. It's the holy grail of imaging. The vast majority of acute events, 50 to 70%, are ascribed to thrombosis after vulnerable plaque. Remember that most sudden cardiac deaths, more than 50%, actually have no more warning signs. So one of the big ironies of the whole process is that you can only do a CT coronary angiogram and look at soft plaque if the patient has got symptoms, yet the people who actually die suddenly without warning are people who actually have no symptoms at all. So there's a major misfit, and it's a problem. It's a real big problem. The fibrous capped atheroma is thought to be the culprit lesion. It often has a lipid core. Sometimes we can see the lipid core on a CT coronary angiogram. There's an urgent need to try and discern vulnerable, unstable plaque from stable plaques. The calcium score doesn't do this. Remember, the calcium score is just that measure of calcium. It's stable plaque, it's calcified plaque. You've got no idea what's going on with soft plaque in that patient. There's some success with the CT coronary angiogram study, but it's also not ideal. There is some hope for MRI, but currently we don't get to see the coronary arteries as well as with the CT. It's not there yet. The gold standards at the moment are really the invasive catheter angio, where the catheter has an IVUS, has an ultrasound probe on the end of it. It's an IVUS, and just like ultrasound elsewhere in the body, it goes through the wall of the vessel into the surrounding tissues, and you can actually assess the plaque. And a little more recently, OCT is optical coherence tomography. The resolution is far superior than IVUS, and it's used in many a lot of study situations, mainly because of the costs involved. But as you can gather, an IVUS and OCT are interventional studies with catheters and exchanging catheters and wires, and it's not without complications and concern. So it's actually very difficult with these to do these techniques just to look at soft plaque, and it remains a problem. Finally, I've put the slide up. It's out of the Journal of Internal Medicine. Getting back to the calcium score, which is what this talk is all about, and I hope I haven't confused you too much, because there are some areas that are a little bit grey and a bit controversial, but basically you can assess the calcium score, you can categorize the patient, and based on the severity of and the 10-year risk categories, you can determine your statin management and the intensity of statin management. You can use it to help a patient with compliance. You might want to follow up patients who have very high scores more frequently and encourage them to get involved in all the risk factor lifestyle modifications, which are going to make a big difference. So thank you very much. Thank you for listening to me. There will be some time for questions.
Thanks so much, Ken, for that authoritative and really comprehensive discussion. We've got quite a few questions, so I'll try and select the ones that I think are going to be most challenging to you. Firstly, people have asked about frequency of calcium scoring. Say how often should it be done if you've got a 0 score or if you've got a moderate level risk?
Okay, that's a common question. I think, as I tried to put across in the presentation, I think that everyone should have access to a first calcium score. It should be provided by the government under Medicare. And I think one deserves a calcium score at the age of 50. One might argue perhaps 55 in a female, 50 in a male. But I think the whole population should have access to the score as a general atherosclerotic screen. In the same way that it's useful to screen mammography and other tests, I think that this one is even more important. As regards how often, I think that about every 5 years is a reasonable time period. One might, in certain situations where there are intermediate scores, one may want to repeat a score to see how the progress is going and to try and assess therapy to make sure that the patient is responding. You might expect, as I said, the calcium to increase moderately if the soft plaque is healing, but on the other hand, if it jumps up significantly over 100 in, say, 24-month period, you're going to be concerned that there's more atherosclerotic disease developing in the patient. They're not responsive. They may need adjustments to medication, risk factors, and you may want to refer on to a cardiologist at some point if you find the calcium scores dramatically changing. So I think there is some value in repeating it. And as said earlier on, also, it's a relatively cheap test, and it's really non-invasive, at $100 to $250. If you think about what people pay for a TV set or to have a hair appointment, it's really not expensive. It's unfortunate that it's not covered by the government. So yes, I think 5 yearly is a good way to have another check if the calcium score is 0. It does change, however, if the patient develops symptoms, but if they have symptoms, they should move on to coronary artery CT or certainly a functional test and perhaps seeing a cardiologist too.
Boone asks, is a high calcium score, if someone's got a high calcium score, should they be referred for coronary angiography? I think you've partly answered that.
Yeah, look, I think if a calcium score is over 400, you're going to be concerned about that patient. I think the first step is to refer them on to a cardiologist. I think they deserve a functional test at minimum. I did say that the functional tests are limited because there's 20% negative predictive value and false positive values, which means 1 out of 10 would actually get it wrong, which is a bit of a concern with functional imaging, but it's still a very good test. 80% of the time, they're going to stress the heart and they're going to give you an answer. Score over 400 is a concern. A cardiologist would decide if they want to get a better look at the arteries anatomically, and they might determine, depending on the picture, if they want to use a coronary CT to do it or to go to a catheter angiogram in some instances. And a lot of that would depend on the patient's symptoms. Remembering that, quite importantly, that not all symptoms are classic cardiac origin. There are a lot of symptoms that can be very atypical, and I think a cardiologist would work that out. So I think certainly with high calcium scores and high-risk patients, strong family histories, very high cholesterol levels, it's important to know when to refer the patient on. But the majority of cases, should be in the hands of the primary healthcare physician, as mentioned previously.
Thanks. Now, Amal asks, the MISA risk calculator doesn't cater for people of subcontinent race. Are there any further risk calculators that you can suggest for this ethnic group?
I'm not aware of any specific MISA calculator. There's certainly, I think it is important to take into account those factors, and there are quite a few publications on the calcium score which do show race differences. I think that the differences, though, are not that major for it to make an enormous change in management. If you do, as I've described, and you put the calcium scores into the calculator, you're going to get very good guidelines. Bearing in mind that the ranges of calcium score in the charts that I've shown you already are already quite broad. We talk about minimal plaque at 1 to 10, mild disease 11 to 100 is quite a broad range, and then moderate disease 101 to 400, and severe disease over 400. So, I don't think that the race ethnic factors are going to change that too dramatically, but I do take the point that the calculator is not optimal for every single race group.
Amal
So
asks,
I'm not 100% sure of the answer to that. I might actually look that up and see if there's another calculator which is more specific for that, for different race groups. And if there is, I'll put that up on the website and answer that question a little bit better next time.
Thanks, Ken. Now, Amal asks, what's the radiation dose during a CT coronary angiogram?
Okay, another good question. It varies a lot. In general, it's very technician and machine dependent. It's sometimes dependent on heart rates. Just to give you guidelines, it should be less than 3.5 millisieverts in most scanners, which, remember, that's the number for the background natural radiation dose for 12 months, just living everyday life at sea level. So that in itself is a very, very low dose. In some scanners, in some situations, you can get that dose right down. I've done some cardiac scans at a DLP of 16. Actually, I think the lowest we had was about 8 or 9, which is just unbelievable. It's actually about half a chest X-ray. It is that low. Now, just by comparison, the calcium score, often the CTCA is a little bit higher than calcium scores, but it may not be. Calcium score requires a KV of 120 as a standard. Sometimes we can do a CTCA at much lower KVs on some machines, 70, 80, 90. That's the amount of energy we put through the tubes, by the way, the KV. And at much lower KV, we can actually come in at very, very low doses. And we tend to use very low doses in younger people when we do these scans in the 30-year-olds, 30, 40, 50-year-olds. In people in the older age group, 70, 80-year-olds, we don't worry terribly much about radiation dose. We try and focus more on the image quality, and a lot of those patients also have calcific plaque, and we need to try and get past that issue. So some of these things are technically challenging. There's no exact number on radiation dose, but generally speaking, it's really shouldn't be an issue in any unit that is providing a quality service. Radiation dose in CT coronary angiogram as a preventative factor or negative factor is a thing of the past. The real big limitation and the real concern, and the only concerns, are really the costs, which are a different issue altogether, and of course the contrast risk from contrast allergy, which is extremely rare, but it's something that the patient has to be fully informed about and fully consented. And that's really the only reason why it's not used as a screening test for screening everyone, because of that risk. If there's a 1 in 100,000 chance of anaphylaxis, that is a concern. I've seen maybe 2 cases in my 30-year career. It's very rare, but you certainly don't want a patient to die on you when you've done a screening test. So the fact that you're giving contrast is the issue more than the radiation dose.
Thanks. Now, Venkata asks, someone with intermediate or high cardiovascular disease risk who's not tolerating statins, can a 0 calcium score help with them ceasing statins?
I think if someone has a high, I think the answer is that if you put the 0 score into the calculator and they still have a 10-year risk of events which is high, in other words, high family history, cholesterol levels, the other factors, then you still need to treat them as for the results of the score, which the calcium score, although it's the most powerful predictor, the others are not insignificant, and you may still have a patient who certainly needs treatment. I think that you've got to remember that the calcium score of 0 shows indicates that there's no calcific plaque, and those patients certainly have a reasonable probability of having soft plaque if they've got, you know, the high lipids and the positive family history in particular. So the answer is no. I still think you need to consider treating them if they're in the high-risk groups. You may want to consider a functional test. I think if a patient is functional test negative and they have a calcium score of 0, you have a very powerful together that you can quite reliably be much more conservative in the management and the treatment. You're probably going to want to follow up and do those tests again in a shorter time period, you know, maybe in another 2 or 3 years' time. Keep a close eye on the patient. You certainly won't jump in and do a coronary CT and do angiograms if they're asymptomatic, but the functional test will hopefully bring out anything that's hidden or lurking in the background, and give a significant peace of mind in not treating or in withdrawing treatment.
Now, Michael asks you, you mentioned that it's not worth doing a coronary artery score in a 60-year-old, calcium score in a 60-year-old diabetic. Could it be worth doing in a 50-year-old asymptomatic type 2 diabetic male who's keen to define his cardiovascular risk?
I think that if that is if that's the test that you have available to you from a availability and a cost and the cost factor in the test, then it's still worth knowing what the baseline cardiac calcium score is in the patient. But the preferable test in an ideal world would be to do a coronary artery CT because of the detection of soft plaque, which is going to ultimately be the primary determinant of whether that patient's in a safe place or not. Unfortunately, as I said, it is the more expensive test, and current guidelines generally indicate its usage for symptomatic patients. But the main reason why guidelines restricted to those patients is because of the negative sides of the test, which are really not the radiation dose, but more the cost factor and the risk of the contrast allergy, which you don't want to have. So, you know, I think it comes down to individualized management of patients. I think a calcium score is a fantastic screening test. I think it's in the hands of the primary physician. I think it should be population-wide. But is it the best test in excluding any disease at all? Well, the answer is no, because it's not an anatomical test. It's just a score, and you can have a score of 0. Now, I did mention in one of the articles that I think it was Harvey Hecht's article that will identify a pool of 95% of acute events will come out of that pool, but there's 5% which won't. And that 5% is 1 out of 20. And, you know, those patients, you know, might have a 0 calcium score, but still have significant issues. And if there's 1 out of 20, you've got to really think about it a little bit. When you're treating an entire population group, it's fine to pick up 95%. And can I just use an analogy here? When we do breast screening work, the breast screening program, which is provided by the government in Australia, accepts a 90% sensitivity. And there's a right at the bottom, up to 10% of mammograms may miss a cancer and you can get a false negative. And the screening program's happy with that. They're happy to pick up 90% of disease because you're going to make a significant impact on the health of society and in the country by picking up those cancers. But it's not 100%. There's a 10% miss rate. In a patient-directed treating situation, often females who have family histories and other risk factors, they may choose to have a dedicated diagnostic laboratory doing the mammography with tomosynthesis and using ultrasound, incorporating it into it, and then any equivocal findings going on to MRI and to other tests. So it's quite a good analogy. I think it's very different when you're screening your patients and you're just looking for a score and you're just looking at the risk profile versus a particular patient who's got particular issues like a really bad family history, immediate family member dying at a young age and in their 30s, a patient with very high cholesterol or a patient who's diabetic or who's obese and overweight, smoking history, you really need to think twice about those patients. And while a calcium score is still an outstanding test, and I think it's a good test to do in that patient and to have their profile, even if it's a baseline, you need to think a little bit wider than that. And perhaps a lot of those patients might need a functional test as well, or in the appropriate setting, one might think about a coronary CT, even though they may be asymptomatic, but provided they are properly consented and they understand that they're asymptomatic. It's not widely recommended in asymptomatic patients because of the risk of allergies, and a decision needs to be made if it's worthwhile having the test. I think the analogy of breast imaging is a really good one there. Another analogy is, I work day to day in a radiology practice where we would do 30 or 40 scans a day with contrast injections for headaches, for brain scans, abdominal imaging. Contrast injections are given for everything from query appendicitis to abdominal pain, all the indications. You would generally, for most cases, give contrast, and it's extremely rare to have major contrast reactions. So, in my work every day, I don't place enormous weight on the contrast issue. Obviously, I don't want to have a fatality and a major anaphylaxis. If I did have an anaphylaxis, and I've had 2 cases, they've been adequately treated and absolutely fine after the adrenaline's been given. So, it's a way up, and everything's relative. So I think it's really important just to go over that. It's to put the patients into the group, which are screening patients, having a look at them, seeing what their risk factors are, and then what you'll find is the intermediate group will get most value, because patients in the intermediate group will be pushed by their MISA score either into a lower risk group that doesn't need treatment, or they may be pushed by the calcium score into the higher risk group, who will then not only need treatment, but may also need functional tests and maybe anatomical tests like a CTCA or even a catheter angiogram in certain instances. And I think the involvement, obviously, of a cardiologist in the whole process becomes that more important in the high-risk patients and the patients with high scores and with significant high risk. I think you've got to be very brave to not treat someone who's obese, smoker, diabetic, family histories, who have a calcium score of 0. I think you need to be quite careful of those